Hi everyone, welcome to episode 8 of the Vet Wrap. We will be discussing today pyrexia of unknown origin with the lovely Dr. Kathryn Hogan, who's one of our internists at Peninsula Vet. And Kathryn, lovely to meet you.
Thank you, Bonnie.
On camera at least, we've never done a podcast before. Do you want to tell our audience a little bit about yourself?
So I'm, guess my main areas of interest are probably chronic disease. I absolutely love cats. I'm a crazy cat lady, and I really enjoy endocrine diseases and GI workups. They're probably my main areas of interest.
Nice. Very good.
What about yourself, Bonnie?
Yes, my name's Bonnie Purcell. I'm also one of the internists at PenVet.
And our new head of medicine.
And recent, head of department, which is very fun and exciting. I think probably my main area of interest is acute medicine, so kind of the flip side of the medicine coin there. I really like acute disease presentations. I like managing hospital patients. I like that ECC medicine intersection. And then within that, there's lots of disease processes I like within that, but I do like GI, renal, liver. So, that's a bit about me.
Yeah. And I guess this is quite a good topic for us because pyrexia of unknown origin, that can really cover the whole spectrum of very acute, very sick patients all the way through to kind of our more long-term chronic management as well. So covers a bit of both for us.
Yes, it does. And pretty much every body system could be affected as well. So it's a nice broad topic. Yep. And we've had quite a few cases in the last couple of months. So we thought this would be a good topic to go over. And I guess broadly speaking, when we're talking about pyrexia of unknown origin, obviously there's a textbook definition for that, which is, a sustained fever for 3 or more weeks duration with no defined cause found, despite doing, some minimum testing, bloods, urine, and being seen by a vet a couple of times. I've just been specific for our chat today, though we are really talking about a general approach to fever, not just cases that have been going on for that long.
Yeah, because a lot of them we see are actually quite acute in presentation.
Yeah, exactly. Yeah. So we certainly see a lot of referrals that may have come through ECC where they've only been sick for a few days versus ones from a general practice referral setting that have been sick for a couple of weeks. They can run that whole kind of gambit. So, and I thought it might be most interesting to kind of take a case-based approach to our chat today so we can kind of speak to each other about how we might approach a couple of classic cases and sort of tease out.
Great. Do you have a good one for me?
I do actually, now that you mention it. So I thought I'd start with our first case as a fairly classic presentation. So I'm going to set the scene. We're dealing with a 3-year-old female spayed Cocker Spaniel who presents to you for a 2-day history of lethargy and poor appetite, and on assessment, temperature of 40 degrees. Oof. Nice and warm, nice and definitively febrile as well. No questions asked there. So, and I'm going to say, vague clinical history, there's really nothing much localising there. Yep. So do you want to run me through how you would approach this case?
Well, I think as with any consultation, any time that you are dealing with a sick patient, the first big thing is getting a really good history. So much of what we do is really good history taking, really good physical exam, and then trying to localise from there so that we can improve our diagnostic yield overall. So first thing, I guess, in terms of history, we want to go through the duration of the problems for this patient. So is it just been a couple of days? Is this something that we've had a previous episode of this before? Did we perhaps, a couple of weeks or a couple of months ago seem a bit off colour or a bit lethargic? And has anything changed from that perspective for this patient? Other things that are really, really important as well is to really quiz the owners about all of those sort of basic processes and go through them in a bit more detail. So I always start off, generally asking the owners what their concerns are so that we can get a good baseline from their perspective, but also making sure that we've haven't assumed that, you know, appetite, thirst, urination, stools have been normal. We actually ask those questions for them and give the owners an opportunity to, nice open-ended questions, but then obviously narrowing it down a bit more to make sure that they have the opportunity to think about these sorts of things and give us information that can help. Other little things I always like to check with the owners as well, obviously any history of vomiting or diarrhea, coughing, sneezing, nasal discharge, eye discharge, any new lumps or bumps, any changes in behaviour. And then we think about kind of the general environment that the patient's been in as well. You know, have they moved house recently? Are they in an area where the patient could have access to toxins? Are they in an area where they could have access to things like, you know, kangaroo poo, or do they feed them raw diets or offal? Things that are going to help us to think maybe more along the lines of, you know, could this be something infectious like toxoplasma or bacterial infection? You know, is this a dog that likes to chew things that perhaps it shouldn't? Do I need to be worried that this is actually like a septic peritonitis? And I think those are all really important things to consider. The other things I think we sometimes forget about is that there are pets that have travelled here from overseas or from interstate. And so sometimes we can see some of those really weird and wonderful infectious diseases. So keeping that in mind, and while obviously tick-borne diseases are quite uncommon in Victoria, and we're really, really lucky, if you've got a pet that's travelled from the Northern Territory or, you know, far north Queensland, Western Australia, we do need to think about some of those more unusual tick-borne diseases occasionally too. So keeping that on your radar, and obviously parasite prevention is also the other thing that I like to just double check as well. So I think that's a good starting point. And then obviously your physical exam is a critical part. And, you know, as you know, so much of what we do is really looking for those subtle changes. And in these cases, it is the small things that really make the big difference. So everyone has their own approach to a physical exam. I like a nose to tail approach, and obviously thinking about each body system as you're going through, you know, starting with the head, you know, is there any nasal discharge? Is there depigmentation of the nose? Does the breath have a really foul smell to it? You know, checking for dental disease. Could there be a tooth root abscess behind this for your patient? We always want to think about each body system individually and make sure that we're evaluating them really thoroughly. And I think obviously everyone knows how to do a physical exam, but this is the time where we really drill into those tiny little small details, you know, checking each joint to see if there's any pain or discomfort. And often with things like our immune-mediated polyarthritises, we'll see discomfort with the digits first. So making sure that we're checking each of those, we're really seeing if there's any joint effusion there, anything that stands out as being obvious or unusual. Watching the patient get up and down. Do they have, you know, that low head carriage? Are they not wanting to move their neck from side to side? You know, little things like just going through your neurological examination and making sure that we're ruling out that there's not any obvious neck or back pain or abdominal discomfort, having a really good listen to your heart and lungs, watching for that respiratory effort, noting if there's any new murmurs, any of those sorts of changes that we can help to perhaps localise where our problem might be. And I think the one thing that people often forget to do is a rectal exam. It's really simple, it's really quick and easy, and we get so much information from that. You know, we want to think about whether or not there could be, you know, if this was a male dog, prostatic issues. You know, can you palpate anal gland masses? You know, does it feel like the sublumbar lymph nodes are enlarged? Is there melena there that the owner hasn't noted? You know, they're all small things, but they do add up and they really do help us to sort of localise where our problem could be. So, yeah, there's some of the, I guess, main things that I would think about. Obviously, you've done your fair share of PUO investigations. Is there any other major ones that you would think about too?
I think the physical exam is really important, and that's something that I think is, like, you know, you are looking for really subtle changes. You're really looking, like, I mean, there's a source of inflammation in the body somewhere, and that is probably going to or could trigger pain. And so we need to be really sort of mindful of checking every aspect we can physically, because obviously there's some, and we'll talk about diagnostic tests in a bit, some big broad brushstrokes that we can take with our testing. But if we can find a localised problem on exam, that's going to be the best way of guiding where we go to next. I think other things are, like in young dogs, bone palpation is another one. I think it's very, you know, when we're thinking about things like hypertrophic osteodystrophy and things like that, you know, you might miss that pain if you're just doing the joints, you know, really palpating long bones. Fundic exam is another one to think about. Obviously, you know, anything to do with the eyes is a little bit more challenging, particularly for junior vets, and I found fundic exams really intimidating.
Yeah, absolutely.
And sometimes still do. But yeah, like you really want to take the time to look at everything. And I think another tip for junior vets is also, this is a good one, if there really is nothing clear going on, to get a senior colleague or someone else to have a look at.
We often do that as well in the clinic.
Even within our team, If I've been struggling with one for a week or two, or even less time than that, I might bring it to you and say, hey, do you mind running your hands over this patient? Tell me what you think. So yeah, I think the physical exam is super important. So I'm going to give you a frustrating situation then. So you've examined this Cocker Spaniel and she's just quiet and febrile and you can't find anything. What do we do now, Kathryn?
Frustrating. And this is not uncommon for us either. So I think the first thing is we want to evaluate the body as a whole. So certainly starting off with our baseline blood, so full CBC, biochemistry, and I always like to get urine, and I think that's really, really important, and it's something that we often miss because a urinary tract infection or a pyelonephritis can definitely be a cause of a PUO, and especially in a female dog, it's always something to kind of keep an eye out for, and it just gives us so much more information. So,
and would you routinely culture that?
Absolutely, yeah. And I think that's one of the things that often gets missed really early in the process is if you think your sediment is negative, that doesn't mean that there's not a UTI there. So it's still a really good idea to actually culture the urine and make sure that there isn't something lurking. And, you know, even if it's not a primary urinary tract infection, if you've got discospondylitis, for example, or if you've had bacteremia, you may still get that localizing in the urinary tract and get an answer that way as well.
Yeah, so I think one of our old supervisors would be saying a urine culture is a poor man's blood culture. And I mean, it's not going to be quite the same, but if that's all you can do, or at least it's part of it, like you've taken some sort of sample, which is, as I said, evaluating the urinary tract, but it might be picking up other things as well.
And I guess I also like to run a CRP at the beginning, which I know not everyone is a big fan of. And I think it's really important to understand the utility of things like C-reactive proteins, especially in dogs. And for me, and I don't know about yourself, but my idea with the CRP is that, yes, it tells me that there's inflammation there. It's not localizing. It doesn't tell me what the cause of that is. It's not prognostic. Having a higher CRP doesn't mean that there's going to be a worse prognosis for my patient. But what it does do is it gives me something that I can monitor in the future. So if we find that CRP is going down really nice and quickly and it's returning to normal with whatever treatment we end up instituting, and I then discontinue that treatment and it goes back up again, I know we haven't completely cleared the problem. Or if, say, for example, if it goes down partially but I'm not getting it normalized, well, perhaps I need to continue with my treatment for a little bit longer. And I think that's really where the utility of it comes in. I don't know if you have any other thoughts or...
I think for CRP, I don't do it as routine, I think, in all my pyrexic patients. Certainly if I find a disease process that I'm likely to be using it as a monitoring tool, I will. So, you know, I certainly use it for IMPA. It's not bulletproof. Like, obviously, you can have remission, the borderline abnormal CRP, and you can also have a dog that has re-emerging IMPA, and I have had that with a normal CRP, but it's just one of those adjunctive in their tools. And also for some infectious disease, like it's been evaluated for use in monitoring response to treatment for aspiration pneumonia, so I actually do use that because sometimes getting follow-up radiographs is a bit tough. So I don't do it in every case, but I definitely see it as a valuable one of our sort of arsenals for monitoring. As a marker of inflammation, certainly in dogs. I probably run it a little bit more in actually the non-febrile lethargic patient, where maybe we're trying to stratify, is this more likely to be inflammatory disease? Speaking with emergency, I think can be useful, for instance, when we've got some neck pain dogs and we're trying to understand, is this more likely to be something really inflammatory like SRMA or disco versus like something soft tissue or maybe a disc, and obviously that's a separate discussion and lots of testing that could be done there. But yeah, I'm a little bit more mixed, but I think I completely agree with your statement. It's a useful monitoring tool, and yeah, it doesn't tell us whether or not it's, and I'm sure everyone knows this, but it doesn't tell us whether it's infectious inflammation,
absolutely,
neoplastic inflammation, immune-mediated inflammation. It doesn't tell us any of that, but yeah, it gives us something to monitor, which is quite helpful.
Yeah. And I guess you mentioned some of kind of the broad categories of things that we think about in terms of causes for pyrexia. So obviously infectious is always the sort of big one that we think about first and foremost, but it's not the only thing that's going to cause a pyrexia. And so, our inflammatory diseases like immune-mediated diseases, our sterile type inflammatory conditions as well, neoplasia certainly can do it too. There is a thought that, pain in and of itself can be responsible for pyrexia, but I don't know that we say that that's the specific cause. So it really has to be a sustained fever that we're thinking about. So those pain ones probably don't fall under this category.
No, and those ones, I guess, when we've got a temperature of 40 degrees, it's unlikely to be attributable just for pain, which is why I made this case kind of in that, very febrile range. Certainly if we have a patient that has a more borderline body temperature, maybe 39.3 and is overtly painful, a simple thing we can do is address the pain and see if that temperature normalises there.
Yeah, absolutely.
So great. So minimum, I guess what we would call our minimum database for this dog, bloods, urinalysis, culture is a great place to start. Where do we move on to then if we find that there's nothing specific there?
Which is really frustrating. And then I guess the next step for us is looking at sort of imaging our major body cavities. So I guess there's always a couple of different approaches that you can take with this, but I like to image the abdomen and the chest if possible at the same time. So either abdominal ultrasound and chest radiographs, or things like a whole body CT. And I think both are reasonable in these sorts of cases, and they're certainly from abdominal ultrasound and chest x-rays, they're things that can be done in general practice. I think the big thing with this though is that your imaging is not going to give you your diagnosis. You still need to get cells from anything that looks abnormal, and I think that's really important. So if you have large lymph nodes, if you see that there is an effusion, if there is something that looks abnormal, get a sample of it. That's the biggest thing that we can do to help us actually reach that diagnosis. And especially when we're thinking about where our next steps will likely be, which, if we don't get any answers and we've done further testing, it might be, antibiotics or corticosteroid trials. So we want to get as many samples before we start to institute any sort of treatment trials. So I think that's really important. I think that's something that does get missed. I would encourage any vets that are out there in practice, if you are doing an abdominal ultrasound, take a sample, get that FNA, obviously so long as it's safe to do so. Don't do it if you've got a coagulopathic patient. But it is a really good idea to collect something and get that process started. And if there is something that you're concerned could be a primary infectious process, pop those samples into a culture medium. So I think that's really important too. We often do miss out on the potential to get a diagnosis because we haven't cultured something. So I think that's important for us to bear in mind as well.
Yeah, and that's something I think we've done a bit. We've had a few lymphadenopathies over the last 12 months that have been centred in the abdomen, and some of them have been, infectious, whether that's been sort of bacterial translocation or other. And sometimes you can FNA those lymph nodes, get your cytology, but if you're finding they're really effusive, when you poke those nodes and you're getting those really juicy samples, we've squirted those onto one of those gel media sort of culture swabs and sent that off.
Yeah, we got a candida result from one, which from an abdominal lymph node is really abnormal. And it did respond to treatment. So that was a really great result for that patient.
Yes, yeah, with such minimally invasive testing as well, which is really nice for the patient, for the owner, and it's a good outcome really.
So then I guess from there, if you're still not getting any answers, then we need to start thinking, I guess, a bit wider. And hopefully by this time point, maybe we're starting to see a few more signs. There might be something that gives it away.
Yeah, over the course of this, repeating your physical exam, I think, is helpful over what time period you're seeing this patient, because certainly things can and do change.
Absolutely. And sometimes that little change is, they're a little bit more stiff. Maybe we do need to consider joint taps for them. So I guess the additional diagnostics I often think about are going to be joint taps, sometimes blood cultures, certainly things like CSF taps, and then if there's any other localizing signs that we might worry about, collecting bile, for example, which I don't routinely recommend, but it is something that perhaps we would consider in certain cases, particularly if there is, changes with our blood work. Supportive of that, because we certainly do see infections there and they can kind of hide away a little bit. I think I said CSF. I can't remember.
You did, yes.
Bronchoscopy, BAL, rhinoscopy, all of those sorts of things, if there's obviously an indication for those. I don't know if you have any other other ones that you generally think about.
I think for me, if I get to the point that I've done bloods, urine, some form of body imaging, obviously including thoracic and abdominal cavity, and if I've got no localizing signs, I do now push for joint taps is probably my next thing. That's going to be guided by signalment.
Absolutely.
For this dog, a young female spayed Cocker Spaniel, that's going to be something that I'm really pushing for, particularly because I've had quite a number of IMPA cases now present with, I've really interrogated those joints and I've gotten no pain, no effusion, and it's very frustrating. And you think, especially if it's been going on for a while, there'll be something, and then there hasn't been, and we've tapped them and they've got really florid neutrophilic inflammation. So I think for me now, I sort of include that one in there, and from a communicating it with the owner perspective, I kind of say, look, we're sedating now for this imaging. If we find nothing on that, then I would suggest we take advantage of this sedation or general anaesthetic and get those joint taps, especially because it's a very safe procedure, again, providing that your patient is not coagulopathic and you're not going to cause a hemarthrosis. It's super safe.
Yeah. And obviously doing it in a sterile aseptic
Yes, of course.
technique.
Yeah, of course. You could also introduce infection and all those sorts of things. But if you're being careful, clean, and it's a very teachable and learnable skill. These are good samples to be able to get.
Absolutely. And when you think about taking your joint taps, how many joints do you usually like to sample?
Yes, the big question. I would typically take 4 at a minimum, and I tend to target the small joints. So carpi, tarsi, so we know that those tend to be predilection sites, and also because those are quite easy samples to get. That's my general rule of thumb. I will certainly take more though. What about you?
Yeah, I tend to do 6, but that was just because it was drilled into me by my supervisor. Yeah. So I think always minimum of 3 is really important, because you just need to be aware if you are doing this. And this is certainly something that our GP vets can do in practice. And I think I was really scared about doing joint taps when I was in GP, but it is certainly something that you can do in general practice. You just need to be aware that if you're getting blood contamination, it is going to make interpretation of your results really challenging. So I think having extra samples in case you do accidentally, end up with a little bit of blood in there and you don't realise it is really important. So in general, you want at least 3 joints that are consistently showing that inflammatory response.
It also helps, I guess, because not every joint is going to necessarily be affected. But obviously, if you're in the lucky situation that this patient has joint pain, you can be like, I'm going to target.
Yeah.
At the very least, these joints, but having more is going to increase the sensitivity of the test overall.
Yeah, absolutely.
Which makes a lot of sense. So, I think that's the thing for me now. I mean, obviously, we can deep dive into a lot of those more specific tests, CSF tap, blood cultures, all that sort of thing. But for me, I think I will often now consider the joint tap if I get through that imaging test and sedation. I'm still seeing
Nothing.
I'm like, well, this is a good point for us to get that sample.
Yeah. And I guess just out of interest for you, if you have a patient that does present to you with a pyrexia and it's got obviously sort of swollen joints, do you do abdominal and thoracic imaging routinely as well?
I definitely offer it.
Yeah.
Again, it's going to come down to the clients and having a discussion. If I've got a dog that's pyrexic joint pain, I'm going to say, look, multifocal joint pain, this is looking like immune-mediated polyarthritis, and I'm going to have a conversation about what that means. Obviously, a lot of these dogs are going to be idiopathic. And also we're going to have a conversation, drug history, vaccination history, when was the last time, etc. But then I'm going to say, okay, well, a lot of the time we're dealing with idiopathic disease. But obviously there are times where this is triggered by something else. And so I'm going to offer, if we want to be complete, this is a nice thing to do, thoracic and abdominal imaging. But if the clients can't afford to do that, then as long as we know the limitations of what we're doing, then I think we can move forward. I think at the very least I will still do blood work and urinalysis and ideally urine culture within that.
Agreed.
Especially because I'm about to immunosuppress this dog. I want to make sure it doesn't have an obvious infectious disease process.
And I think cyclament kind of plays into that a little bit too. You know, if you've got a really senior patient that has suddenly presented with this, you might be a bit more concerned that perhaps there is an underlying trigger like a neoplastic process that is going to set this off and make it more difficult in terms of your overall management too. So, just other things to kind of keep in mind as well.
Yeah, absolutely. So, and I think the only other thing I think about for presentation with joint pain, just because I've seen one case before and it should be on our radar, is endocarditis can present with, I guess, IMPA or joint pain as part of its presentation. So I'll also be having a really good listen for a murmur and understanding how sick my patient seems to be. Yeah. Most of my IMPAs are pretty miserable because they've got really bad joint pain. But if I've got a dog that's really systemically unwell, which doesn't happen very often, that's the dog that I might say, okay, we really should be doing echo and blood cultures because this could be, it's not very common. Yeah. But it should be on our radar that endocarditis can kind of come along.
Yeah. And obviously you're the sort of more acute medicine interest person when we're thinking about more severe cases and things like sepsis. What are those cases where you're thinking about that as being a more substantial risk factor and how would that change your management?
Yeah, so I think if we go back to the beginning and we're represented again with that febrile dog, I think, again, really looking at the patient and saying, okay, on our physical exam, how sick is this dog? Sepsis SIRS, I'm going to be a lot more worried if I have a dog that's dull. Mentation's really important. Again, a pyrexic dog's going to be lethargic or quiet, but if we're in the dull kind of category, I'm going to be more worried. And the other, SIRS criteria, tachycardia, tachypnea, if we're doing our CBC and it's got a marked neutropenia or a marked leukocytosis, these things are going to then make me worried. And then, of course, with shock, if we're presenting with things like hypotension, hyperlactemia, that sort of thing. We should talk about antibiotic trials in a second. And obviously we're touching on before we try and hold off on antibiotics until we've done as much testing as is reasonable, the owners are prepared to do, though that's a discussion we should definitely touch on in a bit. But in that patient, obviously one of the things that is important for sepsis management is early institution of antibiotics. And so for that dog, I'm going to say, okay, well, sepsis is a concern. I might try and get my urine sample at the very least, because that's quick and easy, and my bloods, but then I'm going to start antibiotics and we're going to be really pushing forward for, looking for a source of sepsis. And in dogs often, unless we're worried about a new member, the abdomen is often the place where that is living, or we could have potentially, I guess, a little bit less commonly a pyothorax or things like that. But yeah, antibiotics early is important in that situation. And then, if we are dealing with septic shock, like 4 quadrants, so I'm often going like amoxiclav and enrofloxacin in that situation if we're in a true, shock sepsis situation.
And ideally intravenous, or would you still try and give oral?
Oh, no, I would. I mean, if we're dealing with a dull, shocky patient, oral antibiotics is going to be really probably not practical or feasible to give to that patient. So, yeah, we'll be going intravenous in that situation if we can. I suppose if I was in the situation where I didn't have access to intravenous, subcutaneous would still be better than nothing. But, yeah, getting oral antibiotics into that dog's probably going to be a little bit, you don't know that they're going to necessarily have great gastric motility and all those sorts of things.
And just touching, I guess, on dose rate as well, because I think this is one thing that I do find, you know, for things like amoxiclav, do you have a sort of dose rate that you would think about for these potentially septic patients?
Oh, yeah. I think I'm much, you know, I'm going to be going in the higher dose range. You know, we're going to be, for me personally, sitting around that sort of 25 mix per kg range, Q8.
Yep.
You know, in hospital for that, you know, septic dog. And then for Enro in a dog, 10 mix per kg IV.
Yep.
Slow, obviously, we've got to be a bit careful.
Diluted, make sure.
No seizures. We don't want any seizures here. But yeah, that would be my approach to that one.
Yeah.
I'm just going to have a quick look at the time. My goodness, we've been talking for a little while now, which is good. So I guess that's probably rounds out the dog. I guess the only other thing would be to think about other types of patients we might be seeing if we approach them differently.
Well, obviously being a crazy cat lady, how would you, if this was exactly the same patient presenting to you, but instead of being a dog, we were a 3-year-old female spayed domestic short hair?
Yeah.
How would that change your thoughts and approach to this patient?
I think for cats, infectious disease is overall more common. I mean, dogs' infectious disease is common too, but I guess
if this was a German Shepherd, we might be having a slightly different conversation.
Yes, German Shepherd, we become very breeders and start worrying about things like fungal disease, of course. But yeah, for a cat, infectious disease is going to start to rack up higher. And so I guess one thing I would say, and I want to put this out there, even though there's going to be a lot of senior vets out there that are going to be like, I don't really need this information, but for new grads and junior vets, I think cat fever, have a really good look for cat fight abscesses,
Absolutely.
have a really good look for cat fight cellulitis. I remember being a young vet and missing this and just not having it on my radar.
Yeah.
But it makes a lot of sense. If you're an outdoor cat, abscesses are super, super, super common. Infectious disease is going to become more likely. Part of my minimum database, I'd include retroviral testing. That's going to be part of it. This cat's 3. FIP is going to be on my radar as well. You know, importantly, does this cat have any evidence of effusion? A basic AFAST or TFAST looking for effusion is going to be appropriate. Obviously, also, we could still take a very similar approach to the dog, though. Bloods, urine, and then thoracic x-rays, abdominal ultrasound. So the approach is very similar, but certainly, again, those infectious diseases, particularly a lot of viral diseases, are going to be a lot more common. Thinking about the cat's husbandry, has it been acquired recently? Is it recently from a shelter environment, multi-cat household? Are we getting foster kittens through? You know, thinking about a lot of that is going to be, I think, probably helpful.
Yeah, absolutely.
I guess probably the last thing that I wanted to talk about was, obviously we've touched on a little bit about antibiotics, but I suppose maybe talking about our treatment trials or how we move through those if we can't find an obvious cause.
And I think it really depends a little bit on, if we haven't found anything, what are we worried about and where, if we've done some infectious disease testing or we're waiting on the results. So let's think about things like toxoplasma testing, for example, whether it's a dog or a cat, that's going to take a little while for us to get those results back. It's not going to be straight away. Same thing with our cultures. We're usually going to have to institute something before we actually get our results back, and then obviously adjust our therapy or de-escalate our therapy as appropriate. So with our sepsis patients, we've already mentioned we would probably have them on 4-quadrant therapy. For my general sort of pyrexia of unknown origin, where I haven't found anything particularly localizing and it's an otherwise reasonably stable patient, either something like amoxiclav I often go with, and I do tend to use still a similarly high dose if we're giving that orally as opposed to intravenously, for patients that are going to be going home, for example, while we're waiting on these results to come back or are stable enough to do so. I'd probably do like 25 mg per kg, Q8 to 12 hours. I don't routinely add in things like Enro for our stable patients.
Yeah, me neither.
I think a good alternative, and particularly if you're concerned about, anything neurological, I often do think about clindamycin as well. And I think that's a reasonable thing to consider in a lot of these cases too. So that would be my other option. So something like, 12.5 to 15 mg per kg Q12 hours is the other thing that I will sometimes think about for these guys also. So certainly amoxicillin on its own is reasonable, minimum 22 mg per kg Q8 hours. I find owners struggle a little bit with their Q8 hour dosing just generally.
Yeah.
I don't know how you feel about it. If the patient is otherwise stable and it is uncomfortable, I do sometimes think about using paracetamol, obviously for dogs only, not for cats.
Yes.
But I do think from a pain management and sort of quality of life perspective, we want to get these patients feeling well. So all those supportive treatments are really important too. So our antiemetics, appetite stimulants if you need to use it, but reducing that fever is really important. And I do tend to err away from things like our non-steroidals or corticosteroids, at least in that first instance, because I think if we're waiting on other testing or if we think we're going to need to do further testing, that can certainly really influence our results going forward. And corticosteroids are a pretty big one that we often do use, but can be both a great and a terrible thing. So obviously if you're going to immunosuppress a patient, then you really want to rule out those infectious agents beforehand as much as possible, because there certainly are risks associated with that. And I know corticosteroids are obviously one of your key interest areas.
Yes.
When do you think about using them in these sorts of patients?
Yeah, I think if I'm in a situation where I've got, just say it's again this Cocker Spaniel and I have, I've done, let's say a common situation, we've done the bloods, the urine and the imaging and we can't find anything, I will complete an antibiotic trial first because I want to, I guess, try and do my duty. Obviously, that's not all encompassing. You might give the dog a moxiclav and there is an infectious agent that's not responding to that. The dog could have toxoplasma.
Yeah.
And I will generally try and ride that out for sort of 3 days or so, and then that's a good point to reassess with the owner and reevaluate the dog and have another conversation about, okay, well, things haven't gotten better. We are still in a situation where the dog's febrile. Have another discussion about doing, sorry, excuse me, I'm a bit congested at the moment, doing more testing, and just say I'm at that point where the client will not do anything more. Maybe we've reached our financial limit and there's still no localising findings and the dog hasn't responded to antibiotics and we're saying this could be immune mediated. That's the point that I'll consider it. But I will say to the client, and I will talk about in very real terms what the risks are, which the big one is we could cause your dog to develop a life-threatening or fatal infection.
Yep.
That's the reason that we don't enter into corticosteroids lightly. And I do like to put that in very real terms for the client because I have, seen patients that have had that happen as a result. So I think it's a case-by-case basis when I use it. But I think the main key points I've had is I've sort of done as much testing as is, again, case-by-case process is appropriate. The client will allow me to do. We've tried antibiotics. At this point, we've not seen improvement, and then I will be thinking about it. From a dose perspective, when I don't know what I'm treating, I will enter into it at an anti-inflammatory dose.
That's a great point as well, because I think there's a lot of misinformation and conjecture when it comes to dosing for corticosteroids. So what do you consider to be an anti-inflammatory dose?
Yeah, so if I'm dealing with a dog that is, I base it around at this current point in time, sort of the ACVAM, IMHA consensus statement around dosing dogs by body weight. So if it's a less than 25 kilogram dog, I'm going to be dosing based on a mg per kg basis. An anti-inflammatory, I'm going to be in the range of 0.5 to 1 mg per kg per day. And often when I'm putting my toe in the water, 0.5 mg per kg.
Yeah.
And the reason I'm doing that is I don't know what I'm treating. I want to make sure that we're not going to sort of develop, we could still develop fulminant illness at that, but I'm trying to sort of hedge my bets a little bit there. If it's greater than 25 kilogram dog, then I'm going to be usually dosing at mg per metre squared, because we do have some evidence to suggest that larger dogs are more sensitive, and there's a variety of reasons for that, which could probably be a podcast in itself, more sensitive to side effects of corticosteroids. And so I'm then usually an anti-inflammatory dose at that point is usually for me sort of 10 to 20 milligrams per metre squared.
And meter squared is not something that in general practice I used, I think, at all.
Yeah.
If you're looking for resources on that, is that something that is there anything that you can look up, or how do you work that out?
Yeah, so I mean, I use there's a website called Vet Calculator, which is a pretty easy one to use. You just plug in the body weight. It actually has a variety of things on there that's quite helpful. We put body weight and gives you a meter squared. I think Plums has it as well if you've got the app. A lot of the oncology websites, so like the oncology provider websites have it as well. So yeah, any of those.
Yeah, I do the same. I use a VetCalc, which is an app on your phone as well.
Yeah.
So, it's really important to think about that. And I think if you've got a bigger dog, it sometimes is really interesting to look back and go, well, what was a 1 mg per kg or a 2 mg per kg dose for this, and compare that to what you would get if you were doing a 20 milligrams per meter squared or a 40 milligrams per meter squared.
Yes, it can be quite dramatically different.
Yeah, absolutely. So, and so obviously immunosuppressive dosing if you're needing to use that.
Yeah, so then I would be for, a dog under 25, I typically don't go any higher than 2 mg per kg per day, unless tablet sizing means I can go a fraction over that. For a big dog, then I'm usually, in that 40 mg per meter squared kind of dose range.
Yeah.
What about you?
Same. Yeah, same sort of thing. And I do find sometimes splitting the tablets can help reduce some of the side effects for certain patients, or if owners are really struggling with their dog getting up at night time, certainly using morning dosing is the other thing, because side effects of prednisolone, as we all know, are quite extensive, and I think it's really important to prep and warn the owners about that as well before we
enter into it. Yeah, absolutely.
Which I guess comes to the other conversation that we probably should have, which is expectations from an owner perspective, because I find these are one of the most challenging cases that we end up dealing with, and really from, I guess, setting them up from the very beginning that this could be a very expensive, very frustrating thing to investigate, and we may not get an answer. This could be, I often warn clients we could be looking at anywhere from $2,000 to $10,000 to try and investigate this, but about a quarter of our patients, we won't ever find a definitive answer, and we're going to be in that point of doing treatment trials to really try and improve their quality of life and manage whatever their underlying disease is. But I think it's so important that owners know that in advance. I don't know if you've had similar experiences.
Yeah, I try and set it up very early on. I will have literally the same conversation. I say this could be really straightforward. We might do these first rounds of test and find the answer, which is wonderful. But sometimes we are in that situation. We get through the first round of testing, and that's oftentimes where it starts to become more challenging, which is not to put clients off, but it just helps them be on the journey with you from the beginning, which is to understand that I may do these tests and there may be more tests that we'll be talking about to follow. You kind of set yourself a path forward with them to say, we're on this journey together, but there's going to be potentially a variety of different things. We kind of approach several forks in the road as we go along. We're going to make a decision together. And I use it like a lot of sort of inclusive language. We're going to make a decision about what tests we're doing now. We get through this and then we take that next step. And then each of those are a fork in the road about, are we doing more tests or are we branching off to do that treatment trial now? And there's pros and cons to each approach. So, but I do think you set yourself up more for success if clients understand that early on, rather than them not understanding that this might be a bit of a longer road.
Absolutely. And I guess in terms of referral as well, obviously, we can see patients at any stage in this process, and certainly our really sick, acutely unwell septic patients are probably coming in through our emergency department, and that's very much appropriate. But I guess from a when to refer these patients sort of perspective, do you have any advice for our GPs?
At any point that the clinician feels that that's the best interest of the patient, that makes sense. Otherwise, obviously there's a lot that can be done at general practice level. Like there's a lot of tests that we talked about that could be done prior to referral. Otherwise, I think a good sort of, again, fork in the road moment is before we're considering corticosteroid trials. That's a really good point to be offering it, especially because we were talking about potentially to confound results before. Corticosteroid trials don't always work. And then they can affect the results of testing. So it doesn't mean that the client is going to go for referral, but I think that's a nice other one to mention it, to say, hey, is this the point that you'd like to do that?
Yeah. And in terms of antibiotics, is that something that you're happy for them to come in on antibiotics?
Yeah, I think if, depending on where the dog is at, I think if that trial is underway, you know, I'm not going to say, you know, if that's part of your, you know, rule in, rule out our algorithm. Obviously, if the client wants to come in, you know, and because some clients genuinely want to do the testing before the treatment trials. There are plenty of clients who are like, I just want to try and actually do this properly and get an answer. Obviously, if they're in that camp and they want to go for all the testing first, then providing you don't think your dog's septic, withholding antibiotics for a short period of time and maybe going with paracetamol or something to make the dog feel better makes sense. But I don't have a problem with seeing a dog post antibiotics either if that's just been part of, like, you know, the way that a clinician's been approaching that case.
Absolutely. And I think certainly if they haven't responded to antibiotics within sort of 3 to 5 days, I would probably discontinue. Ideally, being off it for a fraction of time is not a bad idea before we see.
No, definitely. I think if the trial's no improvement, then there's not a lot of point in continuing that.
Yeah, so 72 hours often is good to have them off that antibiotics, I find. And same thing with non-steroidal anti-inflammatories. They can really influence some of our results, particularly with IMPAs as well. So ideally, if we can discontinue those at least sort of...
Yes, we've had a few of those cases recently. Non-steroidals we kind of think of as a fairly... you know, not one to affect testing, but they definitely can for RMPA and SRMA as well.
Absolutely.
So, again, using paracetamol for analgesia or antipyrectic effect is going to be a if it's fine for the patient, preferable.
Absolutely.
Cool. Well, I think that's been a pretty good discussion, Kathryn. Thanks for joining me for
hopefully
it.
People get something out of that.
Yeah, exactly. So, thanks everyone for listening, and thanks for being my buddy on this one, Kathryn. It's been good.
My pleasure.
Cool.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.